Good afternoon, everyone. I have the pleasure of introducing Dr. Randy Walker to give our noon conference today. Dr. Walker is an infectious disease specialist, and if you spend any time in the hospital, you're going to see his name on your charts. Does a lot of work with patients following transplantation as well as with musculoskeletal infections. So he's in the hospital a lot. Dr. Walker also has an interest that he's developed over many years that has to do with reading, and reading for people with some vision impairments. And though currently this is not going into great depth in patient care, he is in the process of continuing to develop technology and inventions that will expand people's reading abilities. And it's currently being tested in a school system out on the West Coast for some children learners. And actually his program also being tested here at Mayo for physicians and other readers of the electronic medical record. So all the efforts and 20 years of investigation and work towards making that easier for all of us, better, faster, simpler. So Dr. Walker, thank you so much for coming today.
Great, thank you, and thank you for coming. Without further ado, we'll get started with this presentation. I wish I had come up with a snazzier title, but this is really the bare bones of how we approach reading, at least with this technology, and we'll get started. I work with our quality groups in transplantation, and this is from the Mayo Quality homepage, or it was. And I think about safety, particularly with regard to the information transfer from one human brain into another human brain, and how much we depend on efficient and clear and effective communication, and how that poses risks in safety. We have a lot of tools in the medical record now, but research shows that patients aren't necessarily struck by how this is improving the doctor-patient relationship. Here's a drawing that a little girl made after her visit to the doctor, and all the nurses and other allied health professionals are talking to the little girl on the doctor's exam table, but she drew the picture of the doctor over in the corner looking at the computer, typing and reading, and so there's kind of a disconnect. And research does show that we spend about 40% of the patient encounter time in the office anyway, actually not looking at or even talking to the patient, but looking at the computer, 40%. The Mayo Simulation Center actually has ways for us to look at a lot of variables in the clinical setting, so they will simulate a patient visit. So here's the computer, the patient sits in the chair, the doctor sits in the other chair, and you can study a lot of interpersonal dynamics in the simulation center, take recordings, and then go back and look at what happened and dissect out issues. Now this is actually what our EMR looks like for a lot of text. Now at any given moment, healthcare providers will be looking at all kinds of data, x-rays, labs, simple reports. But this longer narrative still takes a fair amount of time to read, and just an eyeball estimate, ballpark of the time that healthcare providers spend reading text like this is probably at least an hour a day when you add up all the 5 or 10 minute segments over many patient encounters over the day. And this is a problem because this isn't just a list of words. This isn't just a column of numbers. These are complex sentences. These are the ideas, and the thoughts and the concerns that have been put into English. And they need to be, the Mayo spends a lot of money, as you know, paying transcriptionists to capture what we dictate so that it gets put into this record. But then what happens to it? How do we get that value back up out of the screen and into our brains? And that's kind of the task we're thinking about. back-of-the-envelope estimates. If we look at all these people involved in patient care at different levels, and it said, well, an hour a day of each of these people, add up all the salaries, multiply by that hour, it's a lot of money that Mayo spends every year just to pay our healthcare professionals their time to read text like what I just showed you. And so there's an opportunity to think about efficiency and effectiveness too. Now, it turns out that our medical texts are complicated. They're actually right up there with a legal contract in terms of how the different terminology, the long sentences, the complex sentence structures that translates into, for New England Journal type publications, way up there. What do I have? Grade 18. That number on the side is basically the grade level of the text. Contrast that with, for example, the New York Times. I always thought the New York Times was pretty challenging reading, but compared to medical texts, it's not as hard. And then these are what OSHA would require safety manuals in a factory to be written at. So it needs to be brought down to a more accessible grade level. And even our patient education materials need to be at that level too. And I've actually, after this talk, I was approached by people thinking about, well, what about our hospital summaries or our visits in the emergency room, and we give them this report. And they were embarrassed that they were giving patient reading material that was written on like a grade 15 level, and now they're trying to figure out how to simplify that. There's not a lot of research on healthcare reading in terms of what makes it go up or down. The military, Air Force, had their flight surgeons, and they were concerned about sleep deprivation. And so they showed that if you wake up at 6 in the morning and stay up past 11 o'clock at night, then after 11, your comprehension is going to drop. The brain just doesn't work as well after being up for more than 16 hours in a row. And of course, this is where people are coming from with resident work hour limits and caps on that. English as a second language also will impact on reading performance. So the Scandinavians, you talk to people from Norway and Sweden, their English, it sounds great, and it is. They actually have English on TV, that the children learn English watching television at a young age. A lot of education. Nonetheless, if they look at medical reading, and so the study was they had like a New England Journal of Medicine article, one that was translated into Swedish, the other in English, and then they had the Swedish doctors read back and forth between their native and English. The comprehension drops when you're reading in a second language. So again, back to the Simulation Center, we were putting together some studies with the Department of Medicine Innovation Award, and we were able to capture a fair amount of data. We used a good old-fashioned multiple choice test for accuracy, but we videotaped them to make sure they weren't cheating or anything. And we could also track how much time they spent reading different passages, and we could see what their eyes were looking at any given moment. We randomly selected text with those longer paragraphs in it across different specialties, and we found that the grade level of, this isn't New England Journal of Medicine writing, but it's still the level of writing that we dictate and write and put in notes. It's anywhere from, it tends to be around the grade 12 level, which kind of fits with, how many English classes you took before you switched to pre-medical sciences. That's kind of where. But occasionally the sentences were up, or the paragraphs were up at the grade 17 level, and then it goes down to as low as the 8th grade level. Now this was a surprise. Now the accuracy tests were specialty neutral, so they read medical passages, but the details that they were asked to recall could have and should have been remembered by any person in any specialty. So if the passage was about an orthopedic surgery case, the questions were about what kind of pain medications they were taking, things like that. It wasn't about, well, what's the anatomy, of the spine. So in these specialty neutral quizzes that they took, multiple choice, after reading each passage, we found a very wide range in reading performance. This is just how much they retained, their accuracy score, percent correct. One reader read all the passages and got them all right. Another reader only got 20% correct, and the average is here. So this is still striking when we, as I said before, we expect and depend on fairly reliable, high-level, effective reading. We put a lot of material in there. We give physicians and healthcare providers a fairly limited time to read that, understand it, act on it, make important decisions based on what it had, and yet we really don't know how variable the individual physicians can be in how well they do read. And so this is kind of an eye-opener. This has not been described in physicians before. These were all MD readers from the Mayo Graduate School of Medicine. Details in the back of the talk. But so the study involved 40 physicians who were at different levels of training at Mayo in our residency program. They volunteered to come to the simulation center and spend an hour in that little room reading the things. We also looked at efficiency. Now, efficiency is tricky because, people can speed read, but then they're just skimming, and you can read 500 words a minute, 1,000 words a minute, but does that translate into good retention and comprehension? So we multiply their retention scores times their reading speed to get a handle on the efficiency. And there's also a wide range in efficiency, how many retention-adjusted words per second the readers could read. Again, almost a threefold spread in the efficiency of the physician readers. Now, believe it or not, even though that's kind of a discovery among physicians that, wow, they really vary a lot, and gee, I thought they all got through medical school and everything, so shouldn't they be like the top 5% or whatever of readers? But educators would recognize this widespread in their students all the time. There'd be really bright students who didn't read well. And if that's a really extreme gap, how come Johnny or Susie is super bright, can solve all the problems, and first to raise their hand and very engaging on the one hand, but then you put them in front of a book to read and their scores are low. At the extreme level, of course, people would call that dyslexia. But neurologists in Yale, over 20 years ago now, did a cross comparison between IQ scores and reading scores. And what they found is that at any given IQ, there's still a wide spread, even when you control for IQ. And this makes reading actually kind of a delicate subject, because if people say, well, I'm kind of not a very good reader, or I'm a slow reader, there's two ways interpreting that. Either maybe you have a mild form of dyslexia, but you have a really high IQ, or maybe your IQ wasn't so great in the first place. So people aren't really comfortable talking about their reading performance. This is why when we develop tools, we have to think about keeping it neutral, keeping it like not imposed, kind of just a simple tool that would be there, but not necessarily forced down on somebody. So here's the New England Journal Shaywitz study. And so what you can see here, if you pick this rectangle, and I guess the IQ is about at 130. Nonetheless, there's such a wide spread within that IQ that the people at the lowest level, even though their IQ is the same as the people at the top, they will read no better than a so-called average reader who's 20 points lower in terms of IQ score. So there's something going on in the physiology of reading that interferes with reaching optimal performance based on your IQ. Here's a study at Stanford where they took their freshmen, a bunch of them, and they looked at fMRI, functional MRI, as the students were looking at rapidly turning over information, and it wasn't even letters on a page. It was just they would look at a screen, and it was like these checkerboards that would turn black and white back and forth. And what they correlated that with was the reading ability of the students. So some of this has to do with the visual dynamics of looking at and identifying rapidly turning over visual information. And in a way, it's not natural. What we expect the eyes to do as they read over the page is not a natural use of the visual system at all. So this ability to kind of see a tiny piece of data as your eyes land on a page, and every 250 milliseconds your eyes will move to yet another spot on the page, and you kind of need to rinse out that old data and upload new data and then process it and do that back and forth across row after row. And this is where the biology of the visual mechanics of reading can explain some of this spread between good and more challenged readers. Now here's another opportunity and concern. This is the visual eye span. So when the eyes land on the page, if like a newspaper, if you were to hold like a newspaper about arm's length from your eye, and then look at a column, the high resolution that your retina needs to be able to identify letters and characters on the page, that circle is only about as big as a quarter. Everything else in terms of your visual acuity drops off because it's out of the fovea. You really read character level data in the fovea. There's some parafoveal data too, and we'll talk about that in a little bit. But the other issue with this is that the way words are laid out on the page, we only look at the words in the middle of that quarter, and there's also words above and below the words we're looking at, and they have no meaningful relationship with the two words we're actually trying to focus on. And this creates a kind of a distractor, and the brain actually has to work harder to ignore system and from when it's trying to just think about the words "this must." And so that actually is an extra layer of work. It's sort of attentional focusing work. It's a brain thing. I like this picture because it shows more natural eye movements. So the eyes, all these extraocular muscles and everything, they can go any direction they want. And when you're looking at anything other than text on the page, this is how the eyes actually do move around. They identify salient features in the scene, and they will go back to that point, back and forth, and relate it to other related features. So you can see as they track the eye movements, how there's a more the eyes are almost drawing the picture based on the different ways in which they will move around and build up the representation in the mind's eye, in the visual cortex and higher up. Now, as they look at eye movements in reading, and this goes way back to the 1940s, I mentioned sort of that one word after the other kind of pattern in reading as the eyes move across the page. But there are also frequent regressions, and these occur naturally. They occur subconsciously. You will not be able to force your brain not to do this. It's all very automatic. So look at this top set of words across this row here. Makes the shortwave radio enthusiast resort to. So these numbers in the circle represent the number of milliseconds that the eye would spend on that word. And you'll notice after it gets from enthusiast and goes to resort, it actually has to go back, the reader goes back and looks at enthusiast again. And then it comes back to resort again. It spends even more time looking at and thinking about resort, and then it moves on. Well, what was happening at that moment is that the reader realized that this event was not taking place at a resort in northern Minnesota on the lake for radio enthusiasts. The reader had to say, oh, wait a minute, this is like the other meaning of the word resort. It's like I have to fall back on a different method. And so that's what is called parsing. interpreting the English, finding that verb, knowing that it's not really a noun in that context, but it's actually working as a verb. And so the eyes kind of show what the brain is doing. And unfortunately, because the visual information as you scan across the page has to kind of go in one eye and out the other, the brain doesn't try to remember everything that it looked at. It quickly looks at it, makes a decision, and then lets go of the visual information and moves on. Well, what happens if you find that you had misinterpreted a word or even a few words leading up to that point, you have no choice but to literally go back and look at the word again. And so that's why the eyes had to go back and look at the word enthusiast again, because it had the visual memory had basically washed out that word enthusiast. It needed to be viewed again. So now these verb boundaries, so you're going off of a subject and going into the predicate, just like our English grammar teachers in the 8th grade would help us diagram sentences, and we'd think about how all these words fit together, like a set of Tinker Toy lines connecting with each other. When the brain is involved in that kind of analysis, it literally has to engage whole new areas of the cortex to sort of put the pieces of the puzzle together. It's not just about literally having a word come in, oh, I know what that word means, blah, blah, blah. It's like, oh, wait a minute, I need to kind of build a structure with this. That's the harder and the more complex the syntax is, the sentence structure, the more the brain has to work on this. And this is kind of a psychedelic look at what the brain might really be trying to do as it's organizing linguistic information. This is the first sentence of the Gettysburg Address. So it's this amazing power. The cognitive scientists now are thinking of this as kind of how the brain works for a lot of things. It's called combinatorics. It's a matter of combining things. They also call it recursion. And I think of it as you can find a little set of relationships and you can bundle them in a packet, and then you can take that packet and put it inside of another packet. And that packet might actually be very big and have all kinds of other packets with it. It's kind of like those Russian dolls, with the baby doll and the dolls get bigger and bigger. You can take a sentence and then put it inside of another sentence. And that's what, here's a sentence here, all men are created equal. That's a sentence. And so the brain needs to kind of deal with that on two levels. One, as its own sentence, but also as actually the sentential complement of a term, the proposition that. So it actually is used to help qualify what kind of a proposition is it. What do you mean a proposition? Well, I'm talking about a proposition that all men are created equal. Oh, okay. So that actually modifies the word proposition. And tell me more about proposition. Well, actually, our country was dedicated to this proposition. Oh, okay. So tell me about that. Well, our nation actually had 3 different main things to describe it. It was a new nation, and it was conceived. It was conceived in liberty, and it was dedicated. So you see how that structure starts to hang together with these nested structures. So this is what the brain is doing all the time as it's processing natural language, including reading. Now, it isn't just like an assembly line, like a Model T Ford going down, a track, and different things are being assembled. It's very dynamic. The brain, there's even theories that the brain is like a quantum computer, that can hold multiple possibilities in suspended animation and kind of think about what may or may not be true and how do you balance that with other alternative interpretations, and then finally, the brain says, okay, we're going to decide this is what this means and move on. There's even an electrical signal in the brain, if they monitor EEGs, called the N400 signal, and this particular EEG signal correlates very closely for when a reader has determine the meaning of a sentence. It's like when our grammar teachers told us, oh, a sentence represents a complete thought. Remember when they would say that? A sentence is a complete thought? It's like, well, that actually is really true because it has to be complete. You know, you have to have an action, you have to have somebody doing it or creating it, you have to have the recipient of the action. And if it doesn't hang together as a complete thought, the brain is not going to get that signal. Okay, so then with all this and thinking back about reading, I had an idea. And so this is my idea, thinking about the visual, you know, I talked about those visual things, the eye span, the regressions when you hit a verb, how the brain can actually use all kinds of different cues and feedback to get to that point of really knowing what the sentence means. And so we made some software. We're collaborating with engineers at IBM who are good at this kind of thing. Here's a sentence of the Declaration of Independence, and here's just a cartoon. It just shows that you put it into this machine, and it cranks away. And so this is what the software does pretty much in real time. It can do one of those passages that I showed you in like one sentence. You know, it can do thousands of words because the computers are so fast. But I will talk a little bit more about, well, why do you do it this way? You know, and well, I didn't do it; the computer did it. And so there are rules, there are a lot of rules, algorithms that are trying to identify these main structural pieces, and not only trying to find, okay, where does it begin and end, but also, oh, is it actually inside of another unit, and try to find those relationships as well. It gets pretty tricky, and it's not perfect by any means. But our theory was, well, maybe there's enough there that would actually give a boost to some readers, especially if they were reading, you know, long sentences like this all the time. And this is just a schema of how this really works. This is kind of the method in the madness. These aren't just random breaks. Each break is driven by certain grammatical criteria, the verb phrase, for example, and then how, let's say, a prepositional phrase might be actually a subunit of a larger noun phrase. And then to help add to the decision-making, we also think about, well, how long is this phrase anyway? If a person uses like 5 words, and syntactically or grammatically it's not that complex, but the 5 words are like really long, we might break that down too, just because it's getting too long, and that creates another kind of visual fatigue. Now, research with people who have had strokes, and also research on people who know 2 different kinds of languages, right-to-left languages and left-to-right languages like Hebrew, have shown that there is a little bit of extra brain power in the parafoveal zone, not just in that circle that's about the size of a quarter, but like a little bit more to the side, depending on which direction you're going. And so we're also thinking about, well, maybe if the eyes can gather a little extra data off to the periphery that is still meaningful, what if we put more data that was more meaningfully related above and below the word we were looking at? And so that's the other thing. We're turning paragraphs into poems, you know, kind of E.E. Cummings poems. We've done eye movement studies that actually do show that we keep the eyes moving forward, that they don't have to regress as much. So if you don't spend as much time rereading those words, you have more reading efficiency and speed. This is another study showing that over here, sorry, the mouse is over here, this is the comprehension score, and down here is the speed. We can have, or reading time, we can have higher comprehension in less time. You can have our cake and eat it too there. There's less eye strain, especially if you're reading for more than an hour. These are college students. So back to our medical doctors reading. They had this experiment. This is what they would read in a control condition, and then we looked at how well they could read this way. Now, again, this shows that a passage as long as what I just showed you gets converted in just a couple of seconds. It takes a little getting used to. You kind of have to relax. You kind of have to let go of that more mechanical back and forth motion that you were used to doing. Studies in 9th and 10th graders showed that they really would keep getting better and better with this format over about 6 different reading sessions of about 50 minutes each. So it might seem a little jarring now, but it does come a little easier with practice. Again, this is how some physicians, will articulate their plans and ideas. So what was the impact? It did improve reading efficiency, particularly in those lower groups. Now, it could be that if we just had harder passages and more challenging questions, those people who are getting 80, 90, 100% correct, they just weren't challenged enough and they hit a ceiling. So we can't say for sure that it does not help them. But in the context of this study, we were able to close the gap between the lower groups and the top groups in terms of reading efficiency. The accuracy impact was, again, more in the lower third, not really that much on the accuracy in the middle or upper third. And when you combine these, what we were doing is kind of just showing how much we're closing the gap. We're closing more than half of the accuracy gap between the bottom third and the top third of readers, and we're closing about a fourth to a third of the reading efficiency gap between these poor readers and the top readers. And when you can look at who benefited in what way, we have a group who got both better retention and faster reading. We had a group who had better retention, but their speed was about the same. And then we had people who could read a little faster without losing any retention, but their retention did not get any better. And then a couple more segments who had less eye strain but as their only benefit. And about 20% of the readers will say, I really do read better with the regular text. So we don't want to have this be the new way for everybody, because there will be 20% of the readers who don't like that. And just like Lincoln said, as I would not be a slave, nor would I be a master. So the old block text has been hard for a lot of people in the real world. But that doesn't mean like this other format now has to be imposed on everybody either. It's an option. And we haven't thought that much about options in our electronic medical record. It's really just one size fits all, font size choices, and that's just about it. Back to safety. How would you define safe reading? If you define safe reading as, well, we want all of our readers to read something in a meaningful way, assuming that they have adequate time to do it, and we would really expect them to have at least 70% retention of what they read. Well, we can improve that. We can increase the number of, we can add an extra 20% to the groups of readers who will get at least 70% correct. Same with 80% correct. So again, we can bring people up more to what would be considered a safe level of reading performance. The productivity effects, you can do the math on that. Just by having the same level or better of retention, but being able to get to that point in less time, so you can actually turn away from the computer and talk to the patient, or ask them, do you have any questions? And actually, you're not supposed to say that. You're supposed to say, what questions do you have? What questions do you have? You have a few more minutes at the end of the encounter to do that. I should say that this is where I'm coming from on this. My family and I have a low vision condition. It doesn't get worse as you get old, but computers really are a challenge. And so I've always been motivated to find these tools because it does increase my reading performance too in low vision. Now back to that light bulb. So this is a LED light bulb, right? A light emitting diode in there. It's not the Edison filament. But the people who put this product on the shelf knew, oh, well, they're going to want to screw it into the same lamp. And they want to still use, AC current. And they're going to have a lampshade, too, that they want to clip onto the bulb, too. So you kind of have to make the technology fit in, the rest of, how it's being used. So this is where some of the work now is focusing. We have this engine that can convert English paragraphs into poems, but really, how do you really get it into that sweet spot to impact on reading performance? And there are going to be new options here. You might be able to read the regular way, click a button, and it'll go to the new way. And as we get further along, people say, that's a little too choppy for me. I kind of want the lines a little longer, and that'll be an option as well. And here's some links here if the PowerPoint is available, just so you can demo it yourself with any text you want. I won't do that right now for interest of time, but you're welcome to try that. And the synthesis team is putting this into a little reading button, and it'll mainly work on the HPI, History of the Present Illness, and the IRP, the Impression Report Plan segments that have a lot of words and not much else. It won't parse out labs or medications or things like that, and so you don't want to look at the output on that part. And there will be sample text you can use, and I think coming up on about 8 minutes to 1, is that a good time frame for how we're doing? And we'll open it up to questions. Now, one of the reasons Mary Jurison said she couldn't be here, but she was at a talk similar to this. She said, what about actual patients, not just physicians reading in the medical record? We did get grants from the Department of Education to do prospective year-long classroom studies in middle and high school students. They're very interested in, so many school districts now have a large proportion of kids who speak English as a second language. They're English language learners. So we've got that kind of a study. But we haven't really thought about adults with different kinds of either reading disabilities or brain injury or strokes, for that matter. So here I am. If you have any other, just get a hold of me, Randy Walker, and we'll get in touch and we'll figure out how you could just pull this tool over into your platform off of a web browser. And if you're on the internet, you can have your patient pick a website that they thought they would like to try to read, but they can't, or it's kind of hard, and they can just put the text in that way. Thank you. Today. Okay, is there anybody out in other sites who want to ask questions, or did I get the... Yes.
Well, just a couple comments. This is really great. I think this is really helpful. I guess because I love poetry, and for me it's a real... I love poetry and bullet points. So this is great.
Poetry and bullet points.
But I think, in the real life of looking at the Mayo records, I suggest we'd probably spend way more than an hour. And we're looking through outside records are some of the most difficult. There may be packets of stuff to grind through in addition to the Mayo. And some of the Mayo notes are fairly concise, but one of the problems with the Mayo notes is finding an accurate past medical history and all those things. So I spend more time going back and forth, toggling around in the record, just trying to get the data together. So it'd be nice if somehow that could be cohesively summarized in a format like this or some other format. So, I mean, it's one of many issues, I think, with the records right now.
That's a good idea. Thanks. Yeah. We need, like, IBM's Watson to read our record, too,
Yeah,
I think.
Exactly.
Yeah, to kind of go and
distill things and make
find,
them nice.
and actually you could, Watson could probably double check everybody's so-called past medical history that they had put in the chart on a particular patient, and then see who was out of line with either missing data, or it could actually make a better.
Well, and that was one of my questions. Do you think it's a surprise for healthcare providers to realize that they are inaccurate in their reading? I mean, when you confront people with that?
Yeah.
I don't think I make mistakes.
Right. Well, people, people work around things in an intuitive way. How many of us, if we really want to know what's going on, we'll just pick up the phone and call the surgeon? Well, what are you really thinking here? So they do more of a verbal, speaking way of communicating. Other people will just look at the labs and the x-rays and then talk to the patient and figure they will kind of piece this story together. To me, I think as we move more and more to asynchronous communication, where we don't get to see the people who ask for us to come see the patient off the floor. Remember those days when there was a consult and they actually go to their floor and you talk to the person and then they introduce you to the patient and then you figure out what's going on, and then you step out the door and you talk to the person who wanted your opinion, and within 20-minute encounter, everybody's all on the same page, and there's no misunderstanding really. And then people would write like a 3-line note, like discussed, we'll go for surgery tomorrow, to take out lung tumor or something. I don't know. I think, and that's why this would be presented as a tool. And some people would say, I don't think I would need that, but maybe toward the end of the day I might. I'm getting tired. Some people say, I'm too busy kind of collating all these different fragments of data. It's just to build a note. Now's not the time where I need that tool. It might be more on the receiving end when you're with the patient and they're saying, okay, well, what did the cardiologist say about my chest pain? And so you want to be able to accurately discuss with the patient, what the final conclusions were from that workup. Okay. Well, stay tuned. If you would like to be on the short list of pilot users as this comes out, just send me an email. And you can give feedback to the Mayo IT group. So if you really hate it, or if you really want to kick the tires and give some good objective, but
Your conference is scheduled to end in 2 minutes.
You can give it to the IT people and they will keep it anonymous. Thank you.